I'm like, why isn't Italian in there? Like, seriously.
I can tell you why, because you get grouped in coffee.
I know, and that's not right.
Yeah.
Like, you know, like they're born here.
There's so many differences in the cultures. Like,
Italian is closer to Caucasian than American.
What?
Yes, Caucasian means from the Caucasus of Asia.
But all the time, like, you know,
Russian.
Panamanians get
Basically
mad about
Russian
that.
and Mongolian.
Panamanians are Mexicans.
That's Caucasian. So you guys are closer than we are. We're way on the other side of the planet. You know, when you dig through, straight through the bottom, you come up with what, with the United States and China, right?
And then the back's gonna say, no.
Anna, I gotta tell you, that was a very impressive e-portfolio.
But Lupita, she
I
came out and
really
said
like
she's
that.
from
If I wish I had seen that before I assigned e-portfolio to my freshmen. So I could say, this is what a good one looks like on the team. I might just go into a next year. I should have. Two white girls.
Two white girls.
Okay.
And then the two are under.
Do not classify me. I fit into no ethnicity.
I heard it. Sorry, I tried.
American Indian.
Ohio.
Believe it, I am.
Hey, turn it on.
Irish and Indian, yeah.
I am, but it's not enough to
Is
count.
it Guyanese Indian?
I am
My
Scottish,
grandfather was Irish, my
100%, both
grandmother was
sides.
Cherokee.
You don't have an accent?
My sister looks like a Cherokee Indian down in Colorado.
What's that?
You can see
Yeah, one of the
She's got dark
math teachers,
skin.
or economic teachers, wears a kilt every single day.
Yeah, it was in
Weirdo.
defiance to
Okay, are we ready? All right, take out a blank sheet of paper, write your name on top of it, and answer these 5 questions. Okay, so I can do it like this, and then we have to scroll down. If that's the case, we just do this. This is, I think, is more clear.
This reminds me of high school.
Sure does.
Take out a blank piece of paper, we have a hot one. Okay, we'll take turns.
I have to share my glasses.
Why don't you give her mine?
I'm providing the gift site. I already tried, but they're for near vision.
Yeah, for old people. So you can look.
Okay, you made it big.
I'll give you mine, but they're really bad.
I swear.
By the way, you have 10 minutes.
10 minutes, 2 minutes a question?
Yes,
For how many questions?
for 5 questions.
Oh, okay.
Wait, did we start already?
Yes,
Oh.
You just want the letter?
yes.
Is everyone ready?
No.
Okay.
Has everyone answered question 1?
Yes.
And we can scroll down a little bit, and that should give us the last 2 questions. question number 2 is not saying, what do you need to do? It's what interventions are important in the plan of care after a C-section. Either what has already been done or what you need to do, it's immaterial, but it's what do you do for post-op C-section patients? For post-op C-section patients. Even if someone else has already done it for you. We're ready to move on to the last question. Let me know. And when you've answered question 2, let me know so I can move down. Everyone's answered 2?
No.
Okay. Everyone's done?
Yes.
All right. So let's talk about the questions. Oh, pass them on down here, please.
What do you say?
Yeah. You don't get to like change your answers after we review the quiz, right? Can't do that.
Oh, he's
Grab some
trying.
paper.
Really fun.
By all means. I don't mind saving for you. She was like, all right.
We all love each other so much for that. Right?
Just make that be a
Good try, good try. All right. So I have you know I'm the laughing stock of the school for giving 22 points of bonus questions. But you know, what are you going to do? All right,
Those
so.
things were hard.
Sorry.
Well, no one said you had to say
Dang,
anything.
man.
What's that?
No one said you had to tell anyone.
I missed
Yeah.
that.
I'm a novice, I'm
You have
sharing
no one
with
to
my
blame
more
but
senior.
yourself.
That's fine with me, I don't mind.
Bonus
So,
card.
postpartum woman experienced spontaneous vaginal birth 12 hours ago, describes a headache that is worsening. The patient was given 2 regular strength Tylenol tablets approximately 30 minutes ago, but had no relief from the pain. The most appropriate nursing action at this time is to do which of the following? So first, what part of the nursing process are we in that question? No.
We're evaluating.
Evaluating, exactly. So we have given her an intervention, the 2 Tylenol, and now we're evaluating. And our evaluation was unsuccessful, right?
Right.
So now we need to start at the beginning of the circle again, right? So we've evaluated, it's negative. Now the next step of evaluation is fix the problem. So we go back to assessment, right? But this is an evaluation question and it heads toward assessment.
Okay.
Got it?
Are
So,
you scared there for a minute?
sorry.
I was like,
But the important thing, a lot of people forget about that. They go add pi, stop. Add pi is not a line, add pi is a circle. Continuous all the time. Never ending over and over and over again. So we're going to assess, right? And that's an important thing to understand. We've evaluated our failed treatment and we're moving into our assessment. So ask any visitors to leave or stay quiet. No, right? I mean, that might not be a bad
it's an
idea,
intervention.
but that's an intervention, not an
But that
assessment,
and
right?
the lights kind of go together. If
Exactly.
You're not gonna pick one, you're not gonna
Exactly, dim the lights, the same thing. Notify the healthcare provider. What are those 3 things?
You don't want to call him because
All 3 of those things are interventions, right?
Yeah.
We're in the assessment phase again.
Yes.
So only one of those is an assessment question. Make sense? See how easy nursing is? I tell you, you can do it all day.
I was like, no, it has to be D,
It
please.
has to be D, exactly. A nurse is caring for a woman who just experienced a C-section birth under epidural anesthesia. What interventions are important to include in this woman's care? So, what part of the nursing process are we in?
Planning.
Planning, exactly. We are planning because we know she had a C-section under epidural birth. That's our assessment, right? Now we need to plan her care. So now this is a select all that apply question. So the first thing you have to know is what in there is appropriate care for C-section patients.
I know D.
You know D, huh?
Sure. Yeah.
Okay. Well, let's start with A. Is A appropriate for a C-section patient?
Yes.
It's appropriate for all post-op patients, right? So that's a good one. B, encourage ankle exercises while the woman remains in bed.
she can't feel
No, I mean, that's
But what are ankle exercises going to do? She can't feel her legs, but she can do what? She can move them, right? This is an epidural. So she's got movement, right? And that helps to bring back blood flow and helps to do that. That's not a bad idea. It's definitely not contraindicated. So it's kind of maybe, right? Keep the woman NPO until she's allowed out of bed into a chair. No.
That's cruel.
That's right. Maintain. She hasn't eaten in a while, right?
Yes.
Because anybody who gets an epidural means they labored first. So maintain bed rest until sensation returns to the woman's legs.
Yes.
Definitely,
Eliminate
right?
risk
Not a
of
good
fall.
idea, right? And then allow the woman to hold the infant with supervision while in bed. Or allow, hold on, let me read that again. Only allow the woman to hold her infant with supervision while in bed. Okay? Don't know. So now we know that ankle exercises and only allow her to hold her bed are kind of curious. Right? So now the next question to ask yourself is what is inappropriate care for this patient? What would you absolutely not do?
C.
Make
Okay?
her go to the bathroom by herself.
Keep her NPO until she's out of bed. That's, That's now, ask yourself, why can't she eat? Why would we want to keep her NPO? What post-op patient would we want to keep NPO? Okay, so C-sections are a different kind of abdominal surgery. We don't worry about bowel movements in C-sections because they don't manipulate the bowels. Same reason we don't have to do bowel prep, because we're not manipulating the bowel. We just kind of push them up out of the way. So they used to be NPO until they passed gas. Not anymore. Now we let them eat like right away, whatever they feel like eating. But what NPO patient, what patients who are post-op who are not a bowel patient, would you keep NPO?
Gestational diabetes.
Not pregnant. Which ones would you keep NPO? In general, if you were a nurse on a surgical floor, who would you not be encouraging to eat?
Somebody with swallowing problems.
Okay, someone with swallowing problems. Lots of things will cause swallowing problems, right? You know, the plain old dysphagia that comes along with illness, and someone who is too gorked out to swallow, right? Someone who's excessively sedated. Right? So that's not a C-section patient. She is wide awake and alert. There's absolutely nothing going on with her. She's just numb from the belly button down. She hasn't been sedated. She hasn't been given narcotics. She's purely wide awake in the head. So certainly she's okay to eat. All right? Now let's talk about E. Is there any reason not to let her hold her baby?
No.
No, she's wide awake. She's alert. She's fine. It's just an epidural from the waist down, right? So she doesn't need supervision. She is perfectly fine, wide awake. So it would be inappropriate to separate her from her baby. Okay? So what is the question asking? What is the plan of care for a post-op C-section with an epidural? Apply compression stockings, great idea. Ankle exercises, well, there's no reason not to. Pretty good idea. Keep her NPO, no. Maintain bed rest until sensation returns, probably a good idea, unless you want to write up an incident report. And only allow the woman to hold her infant in bed. Now the key here, why you know this is a no-go, only allow. Those are two ugly words, especially if you put them together. I don't allow anyone to do anything. She is a grown-up. She does whatever the heck she wants to do. Advise her might make it a different question. But only allow is mean old people talk. We don't use mean old people talk in my tests. Okay? So if you see that kind of stuff, you probably know I don't like it.
So close.
Okay? Last time a lot of people said, I heard your voice in the test. You will hear my voice in the questions. That's why I pick them. Because it sounds like me.
Less than 2 cups of
I
coffee.
think about 3.
Okay. 3. The clinic nurse is probably okay, right? So the clinic nurse sees a patient and her infant in the clinic for a 2-week follow-up visit. The woman appears to be tired, clothes and hair are unwashed. She does not make eye contact with her infant. Which question would be most appropriate to the nurse to ask? So this is an intervention question. And before you can do an intervention, you have to come up with an assessment, right? So we need to know what is wrong with this woman. Don't make an assumption. We need to know what's wrong with her, so we need to assess a little bit more. Because do we know what's wrong with her?
No.
We all have a pretty good idea, right? We're pretty sure. But there is more than one thing that could be wrong with her. So this is either late assessment or early intervention. So let's see what we got. Do you have any help at home? Too focused? Okay. Is there, go ahead.
Sorry, because that's making an assumption.
Sure.
That's how I see that.
Could be,
question. It's like
could
you're
be,
making an
yep.
assumption with her.
Is there anything wrong with your son?
I would look at her and be like, that's your job to figure out.
Well, that almost
Okay.
implies.
It implies that there's something wrong with the son, right? And by the way, if this is postpartum depression, is there anything wrong with the baby? No. Okay. Tell me about the first few days at home.
Tell me.
Yes.
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 Why do we like that
Tell
question?
them.
Yes.
Tell
Tell
them.
It's open.
Broad-based, open-ended, she can talk for a half an hour, but she can't say yes or no,
And I heard
right?
your voice. I could
Yep.
hear you.
You heard my
Yeah.
voice in that one, right?
Uh-huh.
Broad-based, open-ended, yeah, that sounds like a good opener, doesn't it?
Yes.
Okay? And what happened? You look awful.
No.
Probably not a good idea. Okay?
Yeah.
So our obvious ones we can automatically throw away are which?
B and D.
B and D, right? Those two are way out there. Throw them away. They're useless. Okay? So that just gets us to our distractor and our right answer. The distractor would be what? A. The one that's kind of close, you read it and went, yeah, maybe. And then you read C and went, oh yeah, that sounds a lot better, didn't it?
Yes.
See how easy it is?
I mean, it's always easy.
Isn't it? Yeah.
This is
Yeah.
how we should take our test.
Yeah, right? That would be wonderful. Everyone would get 100%.
By number 70, I'm like, all right, see.
So I have two primary motivations here. I have to teach you all how to be amazing OBGYN nurses, so I can make life better for all the women out there in North Carolina and around, right? That's my primary motivation. My secondary motivation is that all of you pass the NCLEX, okay? And this kind of thing is how you learn how to pass the NCLEX.
Yes.
The information in these questions is worthless. What matters is, can you answer the question when NCLEX asks you the question? So that's why we're going to spend time going over these things, right?
We really appreciate
Because
it.
we're going to make this better and better and better. I want a 90 on the next test and 100 on the next test, right? So a woman had a C-section birth after a prolonged trial of labor. When assessing the patient, the nurse notes the patient is lethargic, has a pulse of 130, states, I'm glad I have so little lochia. I'm too tired to change my pad. What action by the nurse is most appropriate? So that assumes you already have made an assessment.
Right.
And now we need to act, right?
I changed my
So let's see what we got.
Wait, what?
So, do we assess the amount of lochia on the peripad?
No.
I said yes.
Yes.
Okay, that's
I
not a
said
bad
why.
answer.
Why you want
But
to
it's not
Do we
right.
cluster the nursing care to allow uninterrupted sleep?
What care? What care?
No.
Okay, so I mean, cluster care is an intervention, but is this woman tired?
We don't know.
Let's take a step back for a second, because they've given us enough information. What is wrong with that patient?
We don't know.
She's bleeding, exactly. She is a post-op abdominal surgery patient who is lethargic with a pulse in the 130s.
But why you
She's an
said
adult.
she's bleeding?
Why is her pulse in the 130s?
Where'd you get she's bleeding?
In her abdomen.
Oh, I
Oh,
didn't say
yeah. Everyone in pregnancy thinks the only place you can bleed is out of the vagina. No, she's bleeding into her abdomen because she had abdominal surgery and they nicked a blood vessel.
Oh.
That's why her pulse is 130.
Yes.
That's not in there as a throwaway. That should right there, if you came into the room and you saw a pregnant woman after a long trial of labor, and she said she had a pulse of 130,
That's what I
and what should you do? Automatically, you know a pulse of 130, and anybody who isn't running is in trouble, right?
Yeah.
So that right there, like, you could like put arrows, there like big lines out, like a sunshine behind it,
No, it's
blinking
jazz
lights,
fingers.
right? Jazz fingers,
Yes, there you go.
right? Okay. So we know this. So giving her uninterrupted sleep, you know, with a pulse of 130, she's not tired. She's lethargic.
Yes.
That's a different person. Okay. I know the prolonged labor throws you out, right? And not seeing any blood not seeing any lochia throws you because you're thinking postpartum hemorrhage, right?
No, I wasn't.
But
No? Okay. I'm sorry. I made eye contact. I didn't mean you. I mean you.
Well, I was speaking out loud because you
Yeah.
were throwing out other
Okay.
stuff that I didn't see in the question.
Okay.
So I was trying to.
So clustering nursing care, probably not what's appropriate for a woman with a pulse of 130. Because that means you let her have long periods of uninterrupted sleep. And that's not this woman. Have her get up and attempt to void?
no.
What do you think is going to happen? Well, is that going to do you any good at all?
No.
It's not going to bring her pulse down.
More of
And
a
it's not
habit.
going to make her less lethargic, which are her two big problems, right?
Yes.
So encouraging people to void who are normal, sure, because it's going to help them, right? But encouraging a woman who's bleeding to death to get up and pee, probably not useful, right?
No fall.
Take a full set of vitals and call the provider. After saying all that, does that just jump right out at you as duh?
Yes.
What,
Yes.
in my defense, because I did put A, and this is my logic with A, because when the patient says, I'm glad I don't bleed too much, how do you know how much you don't know?
Uh-huh.
But neither do I.
Sure.
But with you,
And that's why A is the distractor.
right, but.
Because it's close, just not right.
Right, but when you said, like, how did you derive from the assessment was already done just simply by saying action? So, because that's the defining point, right?
Right. it does say what action by the nurse is most appropriate, right?
Right.
And so you know it has to be an action of some sort, right? So it's either gonna be, well, I guess all of these are assumptions,
Yeah.
are actions,
Verbs,
okay?
yeah.
So, how did I don't understand your question, how did I know what?
How did you go to D instead of A? Because to
Okay.
me, when I saw this, the nurse, did not assess the amount of leukemia that was found in the pad.
Okay.
That was the patient, and the patient doesn't have the
Right,
education
it
that I
says
do.
when assessing the patient. So you're
That's why I
assessing
put
the
A
patient.
Okay.
too, because I
So-
was like, oh, she's assessing her. So
You're right,
she-
A is definitely an assessment question, and D is also an assessment question. Which one will give you the most information?
Getting
D.
the other vital signs.
Because it's all the vital signs.
Because it gives you all the vital signs, right?
Okay.
You could make this perfectly clear by saying, take a full assessment, but then that would be too easy, right?
Right, okay.
But what gives you the most information? Loki is a very small piece of it, because we already know she has very little bleeding. And why does she have very little bleeding? Because her uterus is normal. Her bleeding is coming from her uterine artery, or her inferior vena cava. You know, her bleeding is peri-abdominal. And you'll get this on any abdominal patient. Anyone who's had a hysterectomy, anyone who's had a bowel resection. Pulse in the 130s and lethargic means they're bleeding into their gut until proven otherwise. Okay? So the answer would be take a full set of vitals, and the reason it's better than A is because it's a more comprehensive assessment than looking at her lochia. Okay? Because not everybody who's postpartum is having a postpartum hemorrhage.
So
Yes.
in a situation that, like, maybe the pulse wasn't like a
If the
ling,
pulse
ling,
were
ling,
100.
ling. Yeah, like say the
Yeah.
pulse was 100. What would make me,
If the pulse were 100, any of
like, I
these
don't
would
have
probably
enough
be okay.
information, I still
I would
want to
probably, if I
see
had
what
a
else is
normal
going
pulse
on.
and a lethargic patient,
Yeah.
I would say, why are you lethargic?
Okay.
You know, what's going on that makes you lethargic? What's going on that there's something wrong with you, and I don't know what it is. So what's going on? And I would repeat my
Make
assessment
sure it's
over
not
again.
these things, or
Right,
be able to
yeah.
rule. Okay.
Yeah. Then I'd rule out my postpartum hemorrhage. I'd rule out my abdominal surgery. I'd rule out infection. I'd rule out plain old fatigue because she's so tired. But the dangerous ones rise to the top of your list, and the not dangerous ones fall to the bottom of your list. Now, do they teach you guys differential diagnosis? I know that's a medical thing to do, differential diagnosis. But when we talk about differential diagnosis, we say, okay, what could possibly be wrong with this woman? Well, she could be fatigued, she could be hemorrhaging, she could have an infection, she could be, she could have she could have a bleeding artery. You know, there's like 5 or 6 things that could possibly be. Now I'm going to go through and check off my list, each one, and rule out each one. That's why you see that people in the charts all the time, doctors will write, rule out pneumonia, rule out this, because that's what they're doing. They're doing a differential diagnosis pathway, which is a very medical way to do it. Oh, it works like a charm.
Yeah.
But it's not what nurses do.
Right.
But that's how I think when I'm reading these things is, what could possibly be wrong with her? Let's rule out each one as we go through the list. Okay?
That makes
Now,
sense.
let's go on to the last one. A postpartum woman is suspected DVT. Which diagnosis studies does the nurse prepare the woman to possibly have? Select all that apply. Now, first thing you have to ask yourself is, what is it asking? Okay, so we're in the assessment phase of a woman who has a suspected DVT. So we're looking for what possible tests can we expect to be asked for, okay?
Ones that give you visual confirmation.
Okay. Right, so what can we use to rule out a blood clot? Can we use D-dimer to rule out a blood clot?
I couldn't remember.
Yeah.
what it was.
We can, yeah, we can use D-dimer to rule out a blood clot. Can we use an MRI? By the way, is she pregnant or not pregnant?
She's postpartum.
Is she postpartum?
Yes.
Oh yeah, she's postpartum, okay. So she's postpartum. Can we do an MRI?
Yes.
Yeah. Can we do an MRI on a pregnant woman?
No.
Yes, we
Oh,
can.
you, oh,
Sure can.
Because it's
You
not
set us up
radiation.
for that.
I know. Venogram, can we do a venogram?
Don't even know what that is. Is it blood
Okay,
guide?
so if you don't know what it is, let's put that in a, I don't know if that's appropriate or not.
yeah.
Okay, column, okay?
Okay.
So we know what's appropriate so far. We know we can do a lab for D-dimer, we know that'll be helpful. We know we can do an MRI, that might be helpful too. The venogram, I don't know what that is, let's put that aside.
Okay.
Venous duplex ultrasound, any idea?
Yeah,
It sounds good.
Ultrasound for waves, you know, blood flow, yeah. Good idea, right? Definitely sounds good. VQ scan.
No, that's a lung scan.
It's a lung scan, exactly. Yeah. So don't know what it is, but it's a lung scan. Both answers are a good one to put it off to the side. Maybe I don't need that, okay?
But for the ultrasound, is because wouldn't it be contraindicated because if it vibrates, it can loosen up that blood?
Ultrasound is the number one test for DVTs. We use ultrasound and MRI, those two we use ultrasound first, and if that's inconclusive, we go to MRI.
Okay.
Yep. And most ultrasounds are either obvious or inconclusive. Okay, so that leaves us with venogram and VQ scan. Venogram is an IV contrast dye injected in, and then they watch it flow, kind of like when they do a cardiac angiogram. It's the same thing, but it's in the legs. The test bank says it's contraindicated. Your book does not say it's contraindicated. Your book doesn't mention venogram at all. Okay, it's completely null and completely silent on the answer. It says D-dimer, MRI, and venous Doppler ultrasound. Okay, so it says A, B, and D. Okay, doesn't mention venogram at all. All right, but also a VQ scan would be wonderful for a pulmonary embolism, but a VQ scan is not indicated for a DVT. Okay, because why do you have to scan the lungs to check to see if there's something wrong with her leg, right? So it's a different part of the body. Now, test question is answered, gone, put it away. She has a DVT. Tomorrow she has trouble breathing. You bet your butt she's going to get a VQ scan, right? Right. But VQ scan, think of it as a big, huge, expensive test. You don't need it to look to rule out lungs if they're not having breathing problems. You know, this is in the leg. Let's leave it in the leg. Okay? All right. How fun. So we're going to give 2.5 points for each right answer. No penalty for missing the question. I cannot change the syllabus in a negative way. I can only change the syllabus in a positive way. So I can give you things, I can't punish you. Unless I write a memorandum and you all agree, or most of you agree to it, that kind of stuff.
So that's just
But
bonus points going
this is bonus points going to the next test. The next test, there will be 10 bonus points minus 2.5. Because I already gave you 2.5.
That's fair, that's fair.
So the next test, you'll have 7.5 bonus points.
I think it's
Because,
2.5 per right answer.
no, half per answer.
Aw,
Half.
okay.
So 5 questions, 2.5 possible, and we'll do that over the next couple of classes. And we'll total 10 bonus points on the next question, on the next test. And you had a question? That was it. Okay, sounds good. So now we're going to talk about postpartum. I absolutely love postpartum. Why do I love postpartum? Because we get to breastfeed postpartum, of course. I love postpartum, yes.
It's not up here. Okay.
Look under week 6 or week 7.
I think we're week 7 now.
It's 12 to 14.
Yeah.
12 to 14 is the only one you have?
Yes. No, he doesn't post last or after.
There's nothing on week 8.
All right, hold on.
Women.
I know, right? Can't live with
You want me to make a good grade on your test, but you're not giving me the resources I need.
Oh, get it. I mean, but let her get you, but don't let her take away bonus points.
Right.
Are you still doing the private YouTube?
Yeah.
I haven't gotten anything for an invitation.
Oh, I don't have any new private videos.
Oh, okay.
I'm doing my labs, or my lectures up there, open to the
Yeah, that's
public
on the
every day.
public. Okay, that's how it is.
Yeah.
I'm sure everyone is tuning in.
Oh, I'm sure they are.
What?
I mean, Ms. Graham isn't here today, so I hope she's watching the lectures tonight, but
That's by the by.
by the by.
She'll probably email you now because she's watching the recording.
Well, it's it's not live, I'm not live
I
streaming.
mean, tonight, she'll email
Live streaming.
after she watches.
That would be cute if you could figure out how to live stream.
That would be kind of cool, right? Then none of you would come to class.
It's like,
You're like a
at
bunch
least
where
you
we
know.
like read, hey Kiana, we could do like we did for BTN. There's like this thing called Zoom.
Oh,
and there's
yeah.
like you can like raise your hand and everything.
I love it.
Was that?
Do that
I did high school.
around the end of the semester.
It's like up to a
I
certain
did
amount
that
of
in
time,
high
but I
school
think it's 10.
Not the whole time, but.
Oh. The
There,
test
you
taking,
now have slides.
Okay, thank you.
the test taking skill thing for tomorrow?
Ah, yes, 8 a.m. tomorrow, room 104.
Oh, you said nine.
No.
There's a class that starts at 10 a.m. and we can take an hour or we can take 2. It is up to you. I will be here at 8 a.m. ready to teach if you guys want to do it.
Yes.
And I've got all morning. It doesn't matter to me. We could stay until the afternoon if you want. I only have, but that classroom is only available for 2 hours.
Okay.
Is it week 7?
Yes,
It's under week 8.
oh my God.
All right, so back to loving postpartum. Postpartum is the essence of nursing care. It is 100% nursing care. It's not medical care. There's nothing wrong with 95% of these people. It is all nursing care. It's all about comfort, teaching somebody how to adapt to their new environment, and preparing them for the future. That's all it is. It is wonderful, and I absolutely love it. When I left, I was a high-risk OB nurse taking care of HELP syndrome 2 or 3 times a week, and twins and triplets and vaginal breech births and all the sexy stuff, you know. I did a crash C-section in 45 seconds. That was fast. From cut to birth, 45 seconds. I'd never seen a man move that fast in my life. Big Ed Higgins. He tried to run me over with the bed. So we had a baby who was down. We're like, crash C-section, everyone opens. So we did this big, we ran back, and I was driving, and Big Ed was pushing from behind. And boy, that man was moving so fast. I could just barely get in there. So he leaves the bed, like with the head spinning, slams into the wall, wham, while he runs into the room to scrub. And while he's scrubbing, he's yelling, just pour betadine, I'll be there in a second. And I took the tub, a gallon of betadine, but just me and him, there's no one else here. He comes running in the room, knife! I hand him the knife, he goes, baby! I was like, holy cow, Ed, that was amazing. It was a butcher shop, but it got the baby out fast, right? And that was all sexy and exciting, and I loved it. And then I left Germany and I went to Fort Bragg, and they made me a mother-baby nurse. That's like going from flying an F-18 to driving a taxi. I was like, oh, so slow, so boring. This is awful. And I was so miserable that I decided to be a lactation consultant because I could punish people with lactation because they were awful at it. And they were saying everything that I knew was wrong. And I was like, that's it, I'm gonna be the expert on postpartum, on breastfeeding, so I can beat you to death with it because you're so ignorant. And isn't that a mean person to be? I used to be spiteful and angry. And so I became a lactation specialist, and I fell in love with postpartum. Now, and when I came to get my master's degree, I asked the Army to make me a perinatal clinical nurse specialist so I could be on postpartum forever. I wanted to be over there, being a head nurse, whatever, do nothing but postpartum. And the Army said, no, go to midwifery school. Fine, I went to midwifery school. But my heart has always been on postpartum. It's a wonderful place. I mean, the whole thing is good, but boy, I love postpartum. And it gets a bad rep. Everyone hates postpartum. They always talk bad about postpartum nurses, and they say, oh, postpartum nurses, they don't know anything. They know a lot. They're just not medical nurses. They're education nurses. They're bonding nurses. They're loving nurses. They're not medical. They're not ICU nurses by any stretch of the imagination.
They're kind of like a hospice nurse, huh?
Almost like a hospice nurse, yeah. But they're on the another end of the spectrum. I recommend, if you're going to go into mother-baby, postpartum, do a year or 2 in real nursing first, and then go become a postpartum nurse. Or I mean regular nursing. And then go become a postpartum nurse. So you'll know what you're talking about when something bad happens, because something bad will happen, and you're going to end up looking stupid. You know, the big joke in hospitals is the best thing about a postpartum unit is it's close to a hospital. How sad is that, right? Yeah. It's almost in the hospital because the nurses know so very little when things go bad. So you need to know what to do when things go bad, but most of it is not. So we start with the 4th trimester of pregnancy. Before today, had anyone ever heard of the 4th trimester of pregnancy?
No.
There are 4 trimesters of pregnancy, and that is the first 8 weeks postpartum. From the moment the placenta is delivered until 8 weeks postpartum is the 4th trimester of pregnancy. Okay? There's a fancy word for it, puerperium. Okay? Don't bother trying to read it, just say it, puerperium. Okay? Because it'll drive you crazy to try to pronounce it puerperium. No, puerperium. Okay? And nobody can pronounce it, but that's the fancy word for postpartum. Okay? Most people just say postpartum. Okay? But postpartum is the first 6 to 8 weeks postpartum. I keep saying 6 to 8 because it depends on who you ask. Your book says 6 weeks, which is 42 days, which is culturally a wonderful time. But there's an 8-week piece to that that's a little bit different. We might talk about later. What I talk about culturally, does anybody know any cultural background type stuff where in this culture they don't let women do something postpartum for the first so many days? Anybody know of it? What do you got?
So in Korea, the 21 days, which is the 21 days, woman and baby cannot contact with other people other than family. So there's no visitation in the family, in the person's house.
Yeah.
Nobody contact with she cannot go outside. She's not allowed to go outside.
Mm-hmm.
And technically, she cannot take a shower after certain days.
Sure.
So after she delivery, she had to wear like 3-4 layers of clothes, and she had to. It's like she cannot take a shower.
Because birth is hot, right? Is birth hot or is birth cold?
It's hot, but they
Birth
make it
is-
more hotter. So.
Yeah. But I mean, they use hot stuff. They use hot soups and hot clothes
Yeah.
and hot temperature. Birth is hot. Okay. Any others?
Yeah, we have 40 days of bed rest.
How many days?
40 days
40
of
days of bed rest.
Yeah.
Anyone else?
And we have like the belt,
The abdominal binder.
and it stays there.
For 40 days. Sounds good.
I know
Does that
back in,
help with the uterus?
back in the day, you couldn't appear in church for 2 months.
40 days, as a matter of fact.
40 days.
40
you
days.
had to be clean. And
Yep,
you,
yep.
you weren't.
That's Jewish, Muslim, and Christian tradition. Is nothing for 40 days. Okay? Isn't that an odd coincidence that 42 days is what we consider postpartum recovery? Just because we like 7-day weeks? But yeah, 40 days. You know, and what's really interesting about that, if you know your Bible and how it was written, have you ever noticed that in the Bible you see 3, 7, and 40 over and over and over again? In all the ancient texts, ancient Hebrew, Islam, Christian, all the non-religious texts, you see 3, 7, and 40 over and over and over again. Okay, you know why you see 3, 7, and 40? Because these stories were written sitting around a campfire telling stories. 3 means a little, 7 means some, and 40 means a lot. That's where it comes from, 3, 7, and 40. Okay? So Moses wandered for 40 years. It rained for 40 days. Jesus fasted for 40 days. You know, all of those things that's not an accident. Those numbers keep showing up over and over again. Because 3, 7, and 40, it's numerology. It doesn't necessarily literally mean 3, 7, or 40. It just means some, or a little, some, and a lot. That's all it means. But it is pretty universal that all women have a laying-in period postpartum. It's usually somewhere close to 40 days. 21 is the shortest I've ever heard. But there's always something, and that's a recovery period. But that's the recovery period postpartum. It requires, in the initial few hours, our big thing is hemorrhage and complications in the first critical hour. Okay. But hemorrhage is by far the most common of all of our complications in the first hour. Okay? And then the rest of the time is spent doing ongoing education and support. Constantly, over and over again, ad nauseum. Okay? Other considerations that are important are safety. Understand, infant abduction is a big deal. Okay? Huge, huge big deal. No one ever wants to have their baby stolen, and no one wants to be the nurse responsible for letting a baby get stolen. Okay? And the other thing that's very, very important is infant identification. Knowing that you give the right baby to the right mother every time. Okay? And that's very important. So as soon as a baby is born, they get bands put on their wrist and their ankle, and mom and dad get bands. And anybody who's, depending on hospital policy, they usually identify the mother and one other person who gets a band. And that band usually gives them unfettered access to baby, anybody wearing the band. And every time you take a baby away from someone or bring a baby to someone, you check the numbers on the band compared to the numbers that mom and dad are wearing, okay? I've seen them on the wrist, I've seen them on the belly button, I've seen them, various places, usually it's wrist or belly button. And you check your ID bands over and over and over again. I promise you'll get a test question about checking ID bands and making sure that the first thing you do when you bring a woman her baby is to check the ID band, okay? You never want to give someone the wrong baby. Preventing infant abduction starts with ID bands and starts with limiting who has unrestricted access to the baby. And then most hospitals have a low jack system that they put on babies. It's a little box that you'll see on baby's ankle or on baby's belly button. And if it comes anywhere near an exit, alarms will go off, okay? If you go to Fort Bragg and you're walking around with a baby, you'll be walking, when you get like this far from the door, you'll hear beep. And you're like, huh, what was that? I don't know. You get a little bit closer, beep, and you get a little closer, and you clunk, and something will click as the door locks. And if you touch that door, all hell breaks loose. Okay. When we first got the system, it used to be really fun to put the bands in people's pockets when they weren't looking. And then send them out like, hey, can you get me something? You're going to lunch, can you get me a sandwich or something? I don't know, that's great, thanks. And then you walk, it was hilarious. But security got mad at us because it caused too many false alarms. So we had to stop doing it. But that's one step to prevent infant abduction, is to have a baby low jack on, okay? And if they're on a band and you cut the band, if you break the band, alarms go off too. So you can't just cut the band off and take the baby. You have to, if you disrupt it at all, it'll come off, okay? The other great one, have you ever noticed that people in a hospital wear different colored badges? Yeah. It's almost always pink, but there was a hospital in Hawaii, a friend of mine is at, they went to rainbow badges. But they have a distinct color badge. And nobody can use that badge, can touch the baby if they don't have that color ID badge. And moms are taught that as soon as they get there. These are your baby's ID numbers. We're going to check that every single time I see them. And this is a pink ID badge. Nobody takes your baby out of this room without a pink ID badge. And if you're smart, nobody touches your baby who isn't wearing a pink ID badge. Okay? And so when you walk in the room, you identify yourself. They see your pink ID badge. And you'll hear patients go, I don't see your ID badge. Can you show me your ID badge? Whip it out, okay? Anybody who doesn't, anybody who hesitates is automatically suspicious, okay? And there are times when I don't have an ID badge and I'll walk in there and I'll go, I'm not wearing my ID badge, but you recognize me. I'm just going to talk about the baby. And I don't touch the baby unless mom tells me to, because I don't have my pink ID badge. I'm not playing with it because I don't want to, they can trust me, but I don't want to set it up where anybody would think that it would ever be okay to touch a baby without a special ID badge. And those of you who are going to WOMAC, the reason you haven't been cleared yet is they're trying to see if you deserve a pink ID badge. Okay?
Oh, I really want a pink ID badge.
Hey, they're hard to come by. They're special. But, yep. And then the last one, of course, is educating the mother about the safety measures. Okay, all those things I talk about, mom and dad need to know immediately. Okay, as part of the orientation to the floor. Another wonderful safety measure. Have you ever noticed nobody carries a baby in a hospital? Never. Nobody ever carries a baby in a hospital. Okay? If they leave the patient's room, they are in a bassinet, a rolling bassinet like the ones we have back here in our lab. And that does two things. One, it prevents the whoops and fall, which another great prank is to walk around with a mannequin and trail. That just freaks people out. And another one, and the other thing is, anybody who's carrying something bulky on the mother-baby floor needs to be stopped and questioned. What you carrying in that big old bag that could hold a baby? Right? If you're transporting a baby, it is never by arms. It is always in a bassinet. And anybody who's transporting a baby not in a bassinet is suspicious. Okay? Now, hospitals are hard targets. Hospitals, it's really hard to steal a baby from a hospital these days. You got to move quick. Okay, you gotta like have the door propped open, cut the band off, and run with the baby and get off the floor before the alarms go off. But once they get off the floor, they can be out of the hospital and off campus in 3 minutes before security can get to the mother-baby unit to find them. Okay, so that's why we're so uptight about infant security. Yeah, and that's why mom needs to be too, right? So what do criminals do? Do women who want to steal a baby go to a hospital to steal a baby? No. What do? They get them when they're at home. They come and say, hey, I've got baby photos, they're free from the hospital. Or I've got these wonderful signs I want to put in your yard, you know, free from the hospital, whatever. And they get them to open the door and they kill them and they take their babies. Okay, very common form of infant abduction. The most common. Oh, by the way, other safety things. Have you ever noticed that the mother-baby floor is never on the ground floor?
Right.
It's always 2 or 3 floors up. So they have to go downstairs or go down an elevator. It gives a little delay in getting them out the door. And what was the other one? There's one more I was thinking about just a second ago. Oh, it pops into my head like 3 times while I'm talking and it disappears. Never mind. But know that we are fanatics about infant identification and infant security in the mother-baby unit.
Isn't it a locked unit too?
It is a locked unit, yes. Definitely. Locked unit, usually controlled by magnetic key card or by buzz. If you go to Womack, you have to press the button. They have to see your face on the camera and let you in. Okay? And if you work there, you have a magnetic entrance badge that lets you through. All right, so early assessment. So we've assessed that this is a mother who has her baby. Now we have to make sure mom is okay. So we should always see that the temperature is normal. Pulse should be within normal limits. It's not unusual to be a little bit slow. Blood pressure should be within normal limits. Respiration should be within normal limits. And they are not significantly different from any other time in life. Okay, they're in the recovery process. Respirations tend to run, you know, the high side of normal, closer to 20 than 18, but it's relatively immaterial. The uterus, the fundus, should always be at the umbilicus or below. Is that my voice echoing?
Yes.
Yep, it's my voice echoing.
The microphone is off.
It is, I know. But if I turn the program volume all the way down, it stops echoing. It's picking it up somewhere, I don't know where.
The fundus.
See? Gone. All right, so the fundus should be at the umbilicus immediately postpartum and then drop 1 centimeter each day for the first 10 days until it disappears. Okay? It should always be midline. It should never be off to one side or the other. It should always be firm with massage. It doesn't always have to be firm when you touch it. But if you touch it and it's not firm, you give it a little rub, and it should firm up very quickly with just a little touch. Okay? And lochia. There are 3 types of lochia. Anyone know the 3 types? It's based on the color. Cirrus is one. Alba is one.
And then
So we got the clear liquid, we got the white one, and then we got the red one.
the rubia.
Rubra, yes. So lochia rubra is immediate postpartum. Then it goes to lochia alba, then it goes to lochia serosa. And when I'm teaching moms, I say you should have like a heavy period for 3 or 4 days, and then gradually decrease to like a white discharge, and then this increased clearish discharge for the first 6 to 8 weeks postpartum. But it is not uncommon, and it is not unusual for a woman to have bleeding for the first 8 weeks postpartum. It's not heavy, but she continues to have bleeding either on and off or just constant for the first 8 weeks, and there's nothing wrong with that either. Now, if it goes beyond 8 weeks, we start worrying about like a gestational trophoblastic disease or something like that.
Okay.
But it's usually just the first 8 weeks. Don't worry about what we worry about. That's advanced. Okay. I'm not going to ask you any questions about postpartum molar pregnancies. They're so incredibly rare that it's not even worth talking about. Okay? So, how do we do our perinatal assessment? How do we do our postpartum assessment? Mom should always be in Sims position, which is
Left side.
laying back at a 45-degree angle. Left lateral Sims is lying on your left side.
Okay.
Sims is just the head slightly elevated, relax on the bed. The standard patient position is Sims. Okay? And then Rita. Do you guys read about Rita? You guys know who Rita is?
Did I mention we had a test today?
Sure did. It's a perinatal it's a perineal assessment. It's redness, erythema, edema, drainage, approximation. Okay? So what do you think we're looking at? We're looking at her little sister, right? We're looking at her birth canal. And we're trying to get a look from the outside. What do her wounds look like? Okay? Is her perineum excessively red? Is it swollen? Is it all bruised up? You know, is there any drainage coming from her wounds? Is it well approximated?
Erythema.
Rita, yep, erythema. That's the swelling and the redness, right? Yeah. So So Rita comes from the bad old days of episiotomy where everybody had an episiotomy and everybody had a surgical wound to look at, okay? Nowadays, you don't need any of that nonsense. You can just kind of glance, and if you're really worried about them, like they have a 3rd or 4th degree tear, we'll have them roll over on their side and kind of open their butt cheeks a little bit and take a look at the wound. But the only way to properly assess 3rd or 4th degree laceration or an episiotomy is to have them roll them sideline and look at their bottom, okay? Because if you look at them from the top, all you see is her mons pubis and her labia. You can't see the bottom because she's sitting on it, right? So you roll them over on the side for that, okay? Hemorrhoids. Are hemorrhoids common after having a baby?
Yes.
Yeah, they are. They're incredibly common after having a baby. And the good news is they'll go away. They tend to stay there off and on for the rest of your life. Once you have hemorrhoids, you have hemorrhoids. But they usually don't bother you too much, except unless you're like constipated or spending a lot of time on the toilet or something like that. So hemorrhoids are not too big a deal. We just have to teach them some basic comfort stuff.
Which is?
Basic comfort number 1 is ice. Number 2 is witch hazel, tux pads.
Oh, man.
Okay, well, we go through ice and tux pads on the mother-baby unit like crazy. That, and we use a lidocaine type jelly, or lidocaine type cream. It's called,
That foam?
yeah, Epifoam. Thank you, Epifoam. That we spray on the pad and put that right up against the skin. They work wonders. Okay, they're amazing stuff. And then,
Amazing.
if it's severe, manually reposition the hemorrhoids. Any idea what that is? Tell her to stick her finger up her butt and push those hemorrhoids back in. And that'll put that pulls the blood vessels up into the butt and compresses them and takes away that swelling. Because what happens is that they push out into the outside and then they get compressed because everything closes down on them. You got this big distended blood vessel that is being pressed. So you push it back inside and it feels a lot better. Okay? So, the bubble heave. You need to know the bubble heave. Okay? Your book talks about the bubble heave as breast, uterus, bladder, bowel, lochia, episiotomy. Okay? Notice it's missing the he. This is the one I learned. Much better. Breast, uterus, bladder, bottom, lower extremities, hemorrhoids, emotions. Okay? So if you can remember your bubble heave, you'll know your postpartum assessment. And it's basically top to bottom. Okay? Except the hemorrhoids and the lower extremities are kind of mixed. Okay? But the breasts, your breasts should be full, or should be basically in the first 24 hours they should be soft. Second and third 24 hours they should be filling. They should not get firm or hard. They should just be there. Okay. If they're getting firm or hard or hot in the first 48 hours, we're overdoing things a little bit. We're causing engorgement. Okay. You obviously want to check for like breast infections and that kind of thing, but it's very rare to have mastitis in the first 48 hours postpartum. Very rare in the first 6 weeks postpartum. Okay, if you're going to have mastitis, you have like a red hot spot that's real painful to touch. Mom will have fevers and flu-like symptoms. Usually, what you've got is just regular breasts that are they just look like normal breasts. Okay. At about 48 to 55 hours later, moms go through lactogenesis 2, and lactogenesis 2 is what? My milk comes in, exactly. Lactogenesis 2 is when my milk comes in, okay? And that's when they become very firm, and they can be hot to the touch, and moms can run a low-grade temp, about 100.2, 100.5. They're not sick, they're just a little hot because of all the blood flow to their breasts. Okay? When your milk comes in, it is not breast milk, it's blood. Okay? It is not breast milk. Everyone's all trying to pump it out. There's no breast milk to pump out. It's very, very little. It's blood. And all they do is set themselves up for pathologic engorgement. It's awful. So just leave them alone and they'll be fine. You also want to, when you're looking at the breast, you want to look for any trauma or misshapen nipples. We talked about that a little bit last week. The uterus, like we said, should always be right around the belly button, should be nice and firm when you massage it, and it should be going down every day. And it should not be excessively tender. A very tender uterus, like you touch it like, ow, it really hurts, that's a uterine infection. Okay? So when you touch it, all women will be like, yeah, I don't want you messing with that. But there's a difference between that and a fundal tenderness where it really hurts to the touch. Okay? The bladder should be empty, should be able to empty. Okay? If your bladder is full, the uterus is displaced, the bleeding is increased, So we always want to keep the bladder empty. Okay? So we always say, like, we'll look at the pad and see some blood, and we'll say, when was the last time you changed your pad? When was the last time you went to the bathroom? Well, let's get that taken care of and then come on back. You really can't do a fundal assessment if she's got a full bladder because it's not going to give you any real answers. Okay? You're going to get the she's automatically sick answer, and that's not really the case. So we want to make sure she keeps her bladder empty. And when I talk about she should be able to empty her bladder, do you think postpartum women have trouble emptying their bladder? Obviously they do, that's why I'm talking about it. But it's because epidurals and spinals cause problems emptying the bladder. So sometimes they need to have a straight cath, sometimes they need to have a Foley cath left in overnight. Sometimes we can just use a little peppermint oil. Anyone ever learned the trick about peppermint oil yet? If you got a woman who can't pee, put 1 drop of peppermint oil in her hat that she's going to pee in, and it'll help her pee. Peppermint oil releases the external urethral meatus and allows them to pee. It's a great trick. 1 drop. It stinks the whole room up with peppermint, but it works like a charm. Yep. But that'll help them drain their bladder. The other time that we worry about bladder is when we have periclitoral lacerations. We have lacerations that run up along the clitoris or in the urethral meatus. So there's an awful lot of swelling that might cover the urethra. And for those women, we'll put a Foley in postpartum and leave them overnight and take it out the next day and just ice the heck out of it for 24 hours and see how it does. And then try to let them pee the next day. Because God forbid you got a woman who's got lacerations around her urethra and she's all this swelling, and then you got to put a Foley in that, like 12 hours postpartum. It is not worth it. It's better to leave a Foley in overnight and take it out the next day. But the important thing is they have to be able to empty their bladder unrestrained. And why is the bladder so very important? What's wrong? What's their body's fluid system doing in the first 24 to 48 hours postpartum? It's diuresing like crazy. Okay? Urine output in a postpartum woman, it is not unusual to get 200, 300, 500 cc's an hour for the first 72 hours. They pee like a racehorse. Okay? And they have to be able to pee or that bladder is going to get big and distended because their kidneys are working fine. Right? So the bladder is a very important part of your postpartum assessment. The bottom. When we say bottom, we're talking about her labia and her perineal area. Okay? In obstetrics, when we say, tell me about your bottom, we never mean your butthole. Okay? And we certainly don't mean your butt cheeks. We mean your vagina. We mean your labia and your perineum. Okay? So the bottom is the labia. Is there a lot of swelling? Is there a lot of redness? Is there a laceration? Is the laceration healing well? You know, does it hurt? Those kind of questions. Lower extremities, what are we looking for in lower extremities?
DVT.
DVT, of course, right? So we got to check for the DVT. We have them, move their legs up and down. Did you guys read about Holman's sign? Yeah. So we have them flex their legs and see if it hurts when they move their legs. Okay. Most people who have a DVT do not have a positive Holman sign. Okay. More than half do not have a positive Holman sign. If you get a Holman sign, you can be pretty sure you have a DVT. But most people with a DVT don't have a positive Holman sign. They tend to have a little swelling in one leg, and eventually they'll start to get pain there. I have only seen 1 DVT in my career that I've diagnosed myself. Well, maybe a couple. But one that really strikes me was my father-in-law when he had shoulder surgery. He had shoulder surgery, and like 3 days later he came to see us in Rhode Island, and he was like, boy, my leg really hurts. I don't know what's wrong with my leg. And I looked and I measured his calves, and sure enough, one was enormous, the other was normal. I was like, sorry, Joel, you got to call your doctor and go back home because you have a DVT. So the more accurate assessment for a DVT is calf circumference. Okay? But unilateral swelling or pain when you flex your foot should cause you to go right to thinking of a DVT. Okay? Women who are immediately postpartum have a much higher risk of postpartum DVT, and so we need to be always on the lookout for DVTs. Okay? Why don't we take a little break? I just realized it's 2:20. Let's take a little break. We'll come back at 2:30. break, right?
Well,
When I see her top,
She's been on it today
She
though.
was
That's hilarious.
What was that? You were dozing?
Earlier she
because some people are like, I don't worry about it. From the very beginning and whatever. But she tries, and so
She's sitting up like.
when she can't handle it anymore, I know it's time to say, it's time to stop. I understand.
I'm actually paying attention to this.
Me too. I'm not falling asleep. Good. That's so interesting, so I hate
I'm paying
that.
attention to
Have you
this.
guys seen the video of the lemur trying to stay awake? No. It's been on Facebook. It's hilarious.
No, we would tap our eyes.
This is my favorite class, but I
Is
don't,
it?
the Tuesday afternoons suck. I don't know why.
Believe me, I get it.
About to go get some cowboy.
It wasn't there
Annoying.
before.
And if you want it black though, that
Come on, Black.
little what do you call that thing? Like tap in the you know how it has the little color wheel?
I only got one thing. What does that mean? Has it ready yet?
Oh, I know what you're talking about.
Oh, no, here we go.
Okay, that's the same date, so I guess she.
Black.
The one that you glued or whatever.
No, that was the, I always, because I don't like to write them. But, the one I was studying for, I wrote on the front and then I glued it back.
Oh, okay.
So, no, I didn't glue it, I stapled it. Yeah, it looks terrible. Oh my god.
So we have two, right, Carrie?
When you can't say what you want.
Then I got nothing.
What?
Yeah, no.
No, I have honors at 4, so I have to do them. Where are you going?
I see her earlier too.
I need to make sure you guys are my
Yeah,
retard.
Put in a slideshow.
Why? What are you doing?
Huh? What'd you say?
Why?
That's what you all look like, not just you.
That was rude.
That's what I
You know, I'm
see.
lounging.
I see that's hilarious.
I need to verify that you know I'm not a retard. I'm not entered on that thing. I need to put in dresses. Seriously. Like, I can't take a test on. Why? I don't know. Alright, I just had to tell you that.
By all means.
That's
I was doing that.
you just scratched my tattoo.
I didn't do more eyes.
How embarrassing.
No, I'm always in the back of the class standing up, because I cannot sit through a lecture. Oh, it drives me crazy, yeah.
When I study, I'll walk and study my notes real quick because otherwise I'll be like.
Yeah,
Yeah.
it's bad.
Such
And I'm
is life.
obviously very comfortable today, so.
I see.
I'm actually paying attention though, so it's been
I'm-
the secret. I figured it out.
How's that going?
Whatever floats your boat does fine by me.
They know. I never have shoes on, so. Ever.
Is that conducive to your learning?
What?
Bare feet's conducive to my learning.
Is
What are
it?
you wearing this for?
I just see you in the country like trucking through grass.
Oh,
Me?
Yeah.
I got it for Christmas.
I never wear Christmas.
What, Jared?
My dog, he has worms. And so, the vet told me.
The new
You're
one?
not wearing
Yeah.
dress
But he has
or
like
that's
really
what you were
contagious.
Take it back and get the refund.
Well, it was from the pound, so he's okay now. But like when the vet told us, he gave him his second dewormer dose, he told me to not walk in the backyard without shoes
A
on.
small cap.
So I was out there
Really
yesterday
giant
walking in the
cap.
backyard without shoes on.
Then you got worms?
No, I don't have a problem. They're like, he's like, you're gonna get one of those
You
ones.
forgot to say Sonic
Live in
speed.
Boston.
I said, I don't care. What are you
You
doing?
forgot
I
to
don't
say
wear
Sonic
mine.
speed.
Sonic speed.
My mom got married in
Like, my son will
in
do
the
that.
town of Block, Kansas. You know how many people live in
Go,
Block,
Jillian.
Kansas?
Let's go.
About 5. I'm gonna look it up right now and tell you.
And
It's
you
about
gotta
probably-
do it, like to where it like hits.
Darian hits the he oh my god, he goes so
Cause
hard.
I was like, that's what Trey will be like, walking, and he'll be like,
Like what?
like kids are weird. It's even weirder when it's not even yours, and you be like, I saw a kid in my neighborhood when it was raining yesterday in a Superman costume, and I was like, it's not even Halloween. Like, why are you in a Superman costume? Like,
That's all that matters.
Noah dressed up as a police officer like all the time. Whenever he was little, and all the kids would get off on the bus stop, and he'd have this little piece of paper out there. You cannot use profanity in this neighborhood. I was like,
And you were just out there like, why are you looking at me? Like I'm shouldn't be Superman.
He was like 5.
No, this kid was like 9.
Yeah.
I highlighted the whole thing.
Hey, you don't want us to know that, do you?
Guys, it's so small, but they don't have a population on
That's
it.
your color right there.
Really? It won't.
I'm telling you, it's tiny. It's literally like a block. And it has a chapel and a playground. Block Kansas.
I swear I just did that. Now it changed, right?
To my dad. He doesn't understand that.
So you said you were posting an event on Facebook for today?
I think so, look.
John's parents got married at the chapel in Vegas that they always
Did
use
y'all
for
move?
when you have like a little white shower.
No,
That's
we didn't
where
get the
John's
U-Haul
parents
because
got
they were saying,
And then after that.
so we already have stuff packed up. We're gonna go
8
ahead.
days late.
I got married.
5 days late. In Professor Johnson's time, that would be too late for the after hours till whatever.
Whip!
Where are you going with?
All of
I don't have one,
these
that's why I need you to
dances start with a little squat.
Are you laughing at me?
That's the part. You gotta grab your elbow and roll it.
Dare was
I said, I'm not sure.
I saw you been like doing
Yeah, what are you guys
I don't understand why the whole whip and name ever became a
Turn it! Do it! Let's go.
You gotta grab it.
Come on, Whip.
That's not the name.
I do not whip, and I have no interest in your name.
I'm gonna help him. Somebody record it.
Put it in the slideshow.
Record it. You already know who it is. Found it down. Oh no, we're going. I'm singing. I found it down.
I think he
That
does
was
it.
me, Whip. You're being too robotic.
Thank you. You guys are funny.
I got it.
That's the best.
There you go.
I'll post it on Facebook.
Please do. On his page.
That's what I need.
I was about to get to the name and he got robotic.
I was like, I don't know how to whip or name.
Make sure you
Who filmed that?
Me too.
Caitlin got it. She's gonna post it. It's on there?
He's gonna be like, what are y'all doing to me? Watch. Give him.
I can't listen to that song
He was there in the middle.
without that comedian hand. Remember that we went to see on campus and he was talking about the hype man? Can't listen to that song.
We got our ceremonial dance.
Oh, yeah.
Can you do that at the naming ceremony?
No. Half the class gonna whip. Half the class gonna name.
Let's do it.
And then we'll throw a little boost in there.
Can we do
So that's an inverted nipple.
That is an inversion.
Oh, my feet are cold.
Nice.
the Quan?
The Quan.
Can we do the Quan?
How do we do that in our?
That might make it a little hard to breastfeed.
What's up?
That would make it a
I'm
little
so
hard.
close, so I put another pair on. My feet are cold. I did, my feet are cold, sorry.
Let me see.
And you're gonna go off. Is that you?
I don't actually know the word.
That's all.
Want me wheels? Oh, that's
Oh.
awesome. Is my wig dirty?
Genetics or?
My mama told me to do
You keep saying ow like it hurts. It doesn't hurt. If it hurts, they give it fixed.
Wait, who is that?
What?
It's painless?
Yeah. All right, let's get started again, shall we?
It's still recording. So we got it all on YouTube anyway.
For what?
Because whipping and dating, because it's been recording the whole time.
Oh, yeah.
one thing well.
I love it when my little redhead does it. She is not so dedication.
I have no idea where the whole whip and kneading one is.
I know. Well, we had our dances too, though. Like when the first dance would come out, you know. The fresh pin. Oh, who was it? Oh, no, it was Kid Play.
Oh,
remember Kid Play did the dance?
Remember the hammer? Anyway, so what were we talking about? Bottom. So we talked about the bottom, but I think we're done with that. Lower extremities, we talked about that. Hemorrhoids, like I said, they're very, very common in postpartum, in childbirth, altogether. Okay, and that's caused by A, the increase in the serum volume, and B, the laxity in blood vessels, right? Caused by progesterone. So hemorrhoids are very common. And then emotions. We're screening for emotions, postpartum blues, postpartum depression, postpartum psychosis, all those things. We're going to talk about those a little bit more as we move along. So, other things that are important, is she having pain? Should a postpartum woman be having pain? Yeah, a little.
I thought soreness.
Soreness, aches, tired, fatigue, little headaches, those are okay. They're annoying. Tylenol or Motrin does enough, okay? If you need more than Tylenol or Motrin for a normal vaginal delivery, you need to look into that a little bit more, okay? Any woman who takes 2 Tylenols and doesn't feel better needs further assessment. Hence the question, right? Checking their vitals, checking their perineum, checking all kinds of wonderful stuff, and finding out what's wrong, what's causing the pain. Lower extremities, of course, emotional status, bonding. You know, bonding, I love bonding. That women, when they look at their baby, it's like the sun is setting in the baby's face. And the same thing on the other side, right? They're just like, wow, that's amazing. And nothing else happens, and they stare at each other constantly for hours and hours and hours. And it's not even like they're going, oh, you're the most beautiful. They just stare at each other. It's pretty neat stuff. There's an occasional coo, occasional, oh, how sweet. And the voice always goes up 4 or 5 octaves, and that's okay. Okay, that's normal. You got a baby who's never being held, a mom who won't look at her baby. There's something unusual going on there. Okay, so you know what normal looks like, and then when you see abnormal, you go, okay, well, then maybe we need to look a little deeper into that abnormal stuff. So breast assessment, like I said, filling, firmness, a little bit, but not much. No nodules, fissures, cracks, or anything like that. Blood, should you ever have blood on the nipples or coming out of the nipples? Not really, okay? If you've got a lot of nipple trauma from a baby who's being mean to his mother, you need to fix that bad latch. But any nipple trauma at all, even a little bruise, is a sign that we've got a bad latch and we need to fix it, okay? Very common, not normal, okay? People stub their toes, that's why we wear shoes. Because it's common to stub my toe, but I never want to, right? It hurts like crazy. And it's the same thing with nipple trauma. Very common, not normal. Needs to be treated aggressively to make it go away. There is a scenario in which moms will notice blood in their breast milk, that they'll notice like with the first letdown, they'll get like a little bit of blood. They'll even see pink breast milk, okay? It literally is rusty pipes syndrome, is what it's called. And it's just, the blood vessels open, they bleed a little bit into the breast milk. It's not going to hurt anybody, it's not going to hurt the baby, it's not unusual, it's not bloody discharge from breast cancer. It's just a little bit of blood early in the breastfeeding thing, and it usually is self-resolving. It's no big deal, okay? Seeing dried milk on the breast, always a wonderful idea. And then their nipple types. It says erect or inverted, in the middle of that is flat. Okay, there are 3 types of nipples: everted, flat, inverted. Okay, an everted nipple is any nipple that will evert on stimulation. Okay, you see a lot of people have flat nipples when they're not being touched. As soon as you touch them, they pop right out. I think we did that on purpose on a couple of our breastfeeding moms. I may have shown a couple people that the nipples are normal and just relax. And you touch them, and all of a sudden the muscles in the nipple tighten up like that and push, and the nipple itself comes out. That's an erect nipple, okay? It's an everted nipple, even if it was inverted before. If you stimulate it and it pops out even a little bit, it is a normal everted nipple. I get an awful lot of the lactation consultant nurses telling me she has flat nipples or she has everted nipples, she can't breastfeed. There's nothing wrong with the nipples at all, okay? It's just like a man's penis. You don't measure a man's penis when it's flat You measure it when it's erect, right? Same thing if you were going to measure penises. Because they change so drastically with a little stimulation. For the exact same reason, by the way, that blood flows to the area and makes the muscles tighten up. Okay? Now I show you, got a couple pictures here of inverted nipples. Okay? An inverted nipple or a flat nipple is flat or inverted even with stimulation. Okay? So there are two basic types. Okay? There's this one here. And both of them, by the way, what do you think causes inverted nipples?
Is it the muscle?
Not the muscle. It's a connective tissue disorder. It's an adhesion to the nipple inside the breast. So there's some kind of an adhesion holding on to the nipple surface inside the breast, and it won't let the nipple come out. Very much like being tongue-tied, okay? This is a little extra piece of tissue that's holding it. And so what happens is that they're pulled in a little bit, and when the baby stimulates them, they tend to do this. See how it's kind of swollen around the outside? And what happens is when the nipple gets stimulated, the whole thing kind of pushes out, the areola pushes out, and the nipple disappears. Okay? And someone mentioned, yeah, that looks like it'd be kind of hard to breastfeed with that. Yeah, because baby can't get it in his mouth. Okay? And the trick is to get him to open the mouth really wide, and then get him to the breast. And they take the whole area, this whole thing in here, so the nipple itself isn't really necessary. Okay? And those babies can breastfeed just fine. They just need a little bit of guidance. Mom needs a little bit of guidance, because what happens, babies use the nipple to find the breast. Okay, this thing's poking at them. They're feeling like this, like, oh, okay. And then they take it, right?
Yeah.
And if they don't have that nice pointy nipple pointing, babies have trouble targeting. They have trouble finding it. So you have to treat the baby like he's blind and do it so he's not looking, and don't let him seek for the nipple. Just kind of get it to him when his mouth is open. So you trick them with the little rooting thing, and they go, and then you pop them in, okay, and put them to the breast.
Will they tend to feed longer?
No, that doesn't change their feeding behavior at all. But what will often happen, especially when it's a relatively weak adhesion, is those nipples will fix themselves with breastfeeding, okay? Another trick that we use an awful lot for inverted nipples is to pump for a few minutes before we feed. So we pump for like 5 minutes, get the nipples nice and everted and strong, and then put the baby right to the breast when it's standing out. Okay. But again, if I can make it pop out with just stimulation, she does not have inverted nipples. Okay. The problem with inverted nipples is that the areola overcomes the nipple when it gets erect, and the nipple disappears. And it makes a much bigger target for the baby to get into his mouth. Okay? Those women have a lot of problems, and anybody who has inverted nipples needs a lactation consult, because they're at high risk for failing. You can get them surgically repaired. It's not really worth it, but if you want to be a nipple model or something, I guess. And if you do some searches on the internet for inverted nipples, most of the pictures and such is a surgical site where they talk about how to fix it. There's all kinds of wonderful little tricks. There's this thing called the nippolette that they use in France, and it's a little suction cup that goes over your nipples, and you pump it, and it makes it nice and hard, and then you hold it there for a little bit, and you take it off, and you wear a dress that's kind of showing, and your nipples point out, and apparently that's sexy. But
Could you not use
those crazy French.
Could
What?
you not use a nipple guard?
A nipple shield or a nipple shell?
Yeah, that's one that goes over the nipple.
Yeah, so a nipple shell.
Nipple shell, okay.
You can, but that's advanced breastfeeding. With lactation consultants do not want nurses using nipple shells. Okay, we want them to stay away from them, please, because they just cause problems later on. Now, in the antenatal arena, before a woman delivers, usually around 36 weeks, if I know a woman has inverted nipples, I'll give them nipple shields, which are it's a hard ring with a shield over the top of it, kind of like the eye shield that people wear. Okay, and you put that on. There's actually one that's got a large flat ring and a very small circle. You put that on over where the nipple should be, and you wear it from like 36 weeks to 40 weeks, and that can help bring it out. But they have to wear it all day, every day, and they look like they got these things sticking out of their little cones in their bras, so most women won't wear them very much. But the more you wear them, the more likely it is to break the adhesion. Okay? It's not really necessary, but if you can break the adhesion before baby is born, it's a lot better. Okay? Sometimes if it was real bad, we'll practice like nipple rolling beforehand. But what's the problem with nipple stimulation in pregnancy? What is nipple stimulation? It makes you contract, right? Yes. So we don't start until they're like 36, 37 weeks. Until, if they accidentally go into labor, it's not the end of the world. Okay? Now, assessment of the uterus. We've already talked about most of this. The expulsion usually occurs within 15 minutes. Uterine contractions control the bleeding. Technique for uterine palpation, we've covered that on everybody. And that it should involute, the process of the shrinking uterus is called uterine involution, okay? And if it's not working correctly, we have uterine subinvolution, means it's not working right, okay? And uterine subinvolution, you'll see as a symptom of a lot of other things, or a sign, I should say, a sign of a lot of other problems in the postpartum, in the complicated assessment. Fundal assessment, see, I hate when I do it, and I've already covered it all. But it goes down by 1 centimeter today. Fundal assessment, when they talk about consistency, they're talking about how firm the uterus is, okay? And that it should be midline in the belly. After pains. Women, what keeps the uterus firm are contractions, and contractions tend to be a little uncomfortable. A woman having her first baby has very few after pains. They're there, but they're not a big deal. Second, third, fourth, fifth babies, they get more and more powerful as they go along. I always remind people that every birth gets easier and every recovery gets harder the more babies you have. So anybody who has 3 or 4 babies can attest to the idea that they tend to be a little bit more cramping the second, third, fourth time. Okay. Reminds me Jessica's not here. I didn't know that. I just recognized it. Let's see here. What's that? I'm trying, right? It's a lot easier when I think first names instead of last names, but I'm not comfortable saying them yet. So anyway, so what the nurse needs to know is to explain why the after pains are there, that they're uterine contractions, and they get stronger with the second and third baby than they do with the first. Because you always hear, it wasn't like this with my first baby. That's okay. That's supposed to be a little bit more. Okay. I have never placed a woman prone with an abdominal pillow, but I suppose that might be useful. Sitz baths do nothing for after pain, but we use sitz baths to help clean the bottom. Are you guys familiar with sitz baths? Yeah. They're like a little toilet, a little sub-toilet that you put on your toilet, and you run warm water through it, kind of like an enema, but it just goes into the toilet and it washes the bottom without ever touching it with anything. It's a little bit like a little temporary jacuzzi for the bottom.
No. That Italian thing in the bathroom. Bidet, yeah. Like a bidet, yeah. And then, of course, you always want to make sure that moms are getting up and moving postpartum, all right? It does an awful lot of things. 1, it does keep the uterine muscle tight. 2, encourages them to pee. 3, it keeps them away from DVTs. 4, gets them up to do perineal hygiene so that they don't have this old locust sitting on their butt for a long time. You want to get them up and moving. With C-section patients, I am notorious. They are up and moving 6 hours post-op. And they're out the door before 12 hours post-op. So they're out moving around in the hallways by 12 hours post-op. I'm absolutely heartless. Because then, if you do that, if you get your C-section patients up and moving early, you have far fewer complications in the second 12 hours postpartum. They don't have as many infections, they don't have as many respiratory problems, they don't need as much pain medicine, they just get up and get moving. Okay? And then mild analgesics, Tylenol and Motrin. I usually order my Motrin round the clock and Tylenol for breakthrough pain. And I want Motrin round the clock because it works better over a 3-day period than it does from episode to episode. It has to accumulate its effect. We talked a lot about the bladder already. I don't feel like I need to talk about it anymore. Bowel. Everybody worries, why didn't I poop the first day or two postpartum? Why did they not poop the first day or 2 postpartum? Because there's nothing there, right? The baby cleaned it out. If you remember, the last 5 days before they go into labor, they have diarrhea every night, okay? Cleaning out the colon, making it empty. Then they deliver, and that big baby head cleans out anything that was left over in the rectum, and that's fine. They all poop on me, and that's perfectly okay. And then so there's nothing in the bowel, and then they're not going to poop for a day or 2 postpartum, and they worry, am I getting constipated? No, you just have nothing left. It's okay. You'll build up more and poop on the 3rd or 4th or 5th day. And how merciful is that, okay? Like, it's perfect. You get a bottom that's a little bit sore, you don't want to be pooping anyway. So it's wonderful not to have to poop, right? So they don't poop for the first couple of days postpartum, and that's perfectly okay. They just eat and drink the way they want to.
Lokia, we talked about rubra, serosa, and alba already. And documenting the amount. Your book has a wonderful little drawing of the perineal pads. I don't remember the figure number, but it would have to be after breastfeeding, wouldn't it?
15.6.
15.6? Okay, 15.6.
That would be my assumption, because that's what it says on the notes.
Oh, okay then.
I mean,
That's what the slide notes say?
Figure 15.
yes.
There it is. On page 564. You've got a drawing of what minimal, moderate, and excessive looks like. And as a general rule, any woman who's saturating a peri-pad in less than an hour is bleeding way too much, okay? So we want to make sure, we should always see scant to moderate bleeding. You know, there should be some blood on the peri-pad, but not a lot, okay? If, you know, their bladder is full and they've been sleeping for 8 hours and you massage and they get a little gush of blood and it fills the peri-pad, no big deal. Just change it and try again, okay? But if you're seeing this, you know, pretty consistently in the postpartum area, then we got problems, okay? So it's, what we're looking for is 1 peri-pad an hour or less, okay? So if you haven't seen them for 6 hours and you rub the belly and they fill a peri-pad, that's 1 peri-pad in 6 hours, right? That's why it's not a big deal. That's why you clean it up, start fresh, and see what's going to happen over the next hour, okay? Now, if you got a woman who's like an hour postpartum and she's gushing blood all the time, she's a different person. I'm talking about this stuff is the next day or 2 days later, okay? They're late postpartum and they're just recovering. But a woman should never saturate a peri-pad or more at any time, every hour, okay? No matter how postpartum they are. From the moment they're born until 6 weeks postpartum, if they're saturating a peri-pad an hour or more, they're in trouble. And frankly, even if they're not pregnant and your periods are more than a peri-pad an hour for more than 2 or 3 hours, we got trouble, okay? That's too much bleeding. That's menorrhagia, and we might need to look into that, okay? So when we talk about a peri-pad an hour, that's what we talk about. Anyone know how much blood a peri-pad holds? 80 cc's. Episiotomy. Thank God episiotomies are going away. They're usually a 1 to 2 inch surgical incision made by a pair of scissors, and it crushes the tissue. We talked about that as awful. You use Ureta, you use ice for the first 24 hours, generally in 20-minute increments, 20 minutes on, 10 minutes off, 20 minutes on, 10 minutes off. And it's really a low-level ice. We have these pads where there's a little bit of some cold gel in it and then a pad over the top of it that replaces peri-pads. And it's just a little bit of cold just to kind of keep a little direct pressure and ice on the area. And then after 24 hours, we switch from ice to heat. Okay? Why ice in the first 24 hours, heat in the second 24 hours? Okay, ice is for constriction to fight against inflammation, right? The onset of inflammation. And heat does what? It dilates and it clears it, right? So ice for the first 24 hours to minimize the swelling, and then heat for the second 24 hours to take any of that stuff that's accumulated and get it out of there. Okay? So just like on joint injury, I believe they do the same thing. Pain assessment, you always want to make sure you know where it hurts, okay? Not I hurt in my belly. Do you hurt in your uterus? Or do you hurt off to one side or the other? You know, I hurt down here. Where do you hurt? Do you hurt where the incision is? Do you hurt where the laceration is? Do you hurt somewhere else? Is there pain in your vaginal wall or pain in your laceration? Okay. Always, you know, the type, duration, and all that wonderful stuff. We know how to do basic pain assessments. They're the same postpartum as they're anywhere else. They're just focused on reproductive organs. Sitz baths we talked about, and non-pharmacologic pain measures. Things that moms can do to make themselves feel better, like ice and heat, like keeping their bladder empty, like you doing perineal care to take care of themselves, those kind of things. DVTs, Holman sign is a very classic sign. Like I said, it's not usually present, but if you flex the foot and you get pain in your calf, you want to make sure that they don't have Holman sign. It is often like a false positive thing because women have generalized muscle soreness. And you can kind of rule it out. Does it hurt when you do it on both feet? Yeah, okay. Well, you're just a little sore, All right, chances of a DVT in both legs is pretty darn low. But if it only hurts on one side, you got swelling and pain all associated with it, you want to make sure you look into it. And the trick to it is never ignore the idea. At least give it a passing thought. I wonder if she has a DVT. Let me mash around in there and see what's going on. Okay? Clinically what you'll see is swelling, unequal calf circumference, and heat. And by the way, when you measure calf circumference, what I do and what I was taught is the process at the top of your tibia, that little bump there. Put your index finger on that. Go 1, 2, 3, 3 fingers down, and put a little mark on it with a pen. And then do that on both sides, and that's where you're going to measure. And that is the middle of the calf. Okay. But what you do when you do that is that you identify the exact same spot on both legs. Okay. You're not measuring the biggest spot. You're not off by half cent because it's a curving organ, right? A curving muscle. So if you measure it here on this leg and here on this leg, you'll have 2 totally different measures. So it's got to be the same spot on both calves. And I use the 3 fingers from the process on the tibia. Okay. And it should be, more than a centimeter or 2 apart. Emotional status. So it is very, very common to have highs and lows, ups and downs, ecstatic and crying all at the same time in the initial postpartum arena. Okay, there's this thing called baby blues. Right, baby blues is usually a self-limiting disorder. It starts around 48 hours postpartum, runs for a day or 2. I generally say you wake up one day, you don't feel very good, just a little bit run down and tired, and you hate dad, and everything else is okay. Okay? And usually by dinner time you're a lot better, and the next day you wonder why you were in such a bad mood yesterday. That's baby blues, okay? It's self-limiting, it doesn't interfere with your daily activities, it's just annoying, okay? Frankly, I think it's a lack of immediate skin-to-skin contact, because now that everybody goes skin-to-skin, I never see baby blues, okay? It's very uncommon. It used to be every single woman had it on the 3rd day postpartum. Now I don't see it very much. But then it's self-limiting usually in the first week or 2, okay? Almost always day 3 and 4. Then there's postpartum depression. Postpartum depression is an actual depression, okay? It is characterized by feelings of guilt and inadequacy, profound and long-lasting, I just can't get anything done. I don't want to eat, I don't want to sleep, I don't want to let the sun shine on my face, I don't want to take care of my baby, I just don't want to do anything. I feel useless and I feel guilty and everything is my fault. That's postpartum depression, okay? It generally lasts more than a few weeks. We usually pick it up either at the 2-week well baby checkup when they come in for their pediatric exam, or at the 8-week well mommy checkup. But anytime in the first 6 months that mom has depression, it's postpartum depression. Okay? We use a score called the Edinburgh Postpartum Depression Score, and they answer all the questions. They grade them at 0, 1, 2, or 3 points for each question, and a score of 13 or higher is usually postpartum depression. Okay? But what's important to understand about postpartum depression is that it's very, very real. It happens and it needs to be treated. Because women who have postpartum depression who don't get treated have babies who are emotionally and developmentally delayed. They don't eat well, they don't sleep well, they don't drink well, their babies are upset, they don't learn how to crawl the same time other babies do, they don't learn how to talk the same time other babies do, and mommies can slip into this suicidal stuff, and that's not good either. So we need to assess for it, understanding that being a little rundown is okay, being a lot rundown is not okay. All right? Now, hematologic system. So the blood volume is going to decrease rapidly after the baby is born. The white cells are going to be increased during labor and a couple of days postpartum, and that's okay. And the fibrinogen tends to be increased for initially and then return to normal. And that is just a simple response to stress, right? That's plain old birth. It's working hard. If you ran a marathon and then got in a car accident, you probably have the same problem. Okay? Hormones, your estrogen and progesterone, are going to decrease. And what's really fascinating is that progesterone drops to 0, almost like within 48 hours of the placenta being delivered. And when the progesterone drops to 0, the prolactin kicks into high gear. Okay? It is the absence of progesterone that causes lactogenesis 2. Okay? So Progesterone runs fairly high throughout all of pregnancy, builds at the end of pregnancy, and then at the delivery of the placenta, progesterone disappears, and prolactin takes off. Okay? Prolactin rises rapidly from 20 to 30 in serum up to 50 and 150 to 400 in the first week or so postpartum. And it is that surge in prolactin that causes the breast to start to transition from colostrum to mature breast milk, and then you get the full breasts, and you start to make that mature breast milk. Okay? Now understand, I said it more than once. It is the absence of progesterone, okay, caused by the complete removal of the placenta that causes lactogenesis too. Okay? Because progesterone is a placental hormone. Okay? So if you have a woman with retained products of conception, a little chunk of placenta left in the uterus, do you think she's going to breastfeed? No, she won't get lactogenesis too because there's still placenta in the uterus. So they have to get rid of the placenta in order to be able to breastfeed. Okay? That's a big deal when it comes to trying to figure out why women are struggling with breastfeeding. Because they've got placenta pieces left behind. You need to make sure they don't. Okay? Yeah, you order an ultrasound. Usually the ultrasounds are inconclusive. You give them if they've got bleeding and kind of a larger than expected uterus, and it's a little boggy for 2-3 weeks postpartum, I give them a series of Metrogen, it clears them out, and then they're usually better the next day. Okay? The insulin levels, insulin needs decrease immediately postpartum because their insulin resistance has gone away, right? And all of a sudden women who were diabetic are no longer diabetic. Women who were type 2 diabetic or taking insulin find their insulin requirements drop drastically, drop even lower than pre-pregnancy needs for a while. Okay? And the treatment for gestational diabetes is to deliver the placenta. As soon as women are taking their blood sugars 4 times a day, every day from 28 weeks to delivery, as soon as they deliver, we stop taking their blood sugars. And they say, why don't you take my blood sugars anymore? Because you're not diabetic anymore, because you lost the placenta. Okay? It's fine. We check them again 2 months postpartum, and then again every year for the rest of their life, just to make sure they don't develop diabetes later. But a woman with gestational diabetes is cured by the pregnancy 75% of the time. Okay? Again, with this altered sleep patterns, absolutely not. It's not an altered sleep pattern. It's that being a mom is a nocturnal event. Okay? And when you spend all day long playing host and hostess, making sure everybody else is taken care of, cooking and cleaning and bottle washing, and doing all the stuff that you need to do to be a good mother, and then baby's like sleeping all day long, guess what? Your baby doesn't care if your house is clean. Your baby doesn't care if you've done the dishes. Your baby doesn't care if you've written your thank you cards. Your baby could care less what you do all day. All your baby cares about is when they're awake, you're awake. And they are not going to tolerate you not being awake. Okay? So it's not an altered sleep problem. It's not a disorder. It's that women who become pregnant are not human. And women who have babies are not human. They are different people, and you have to treat them differently. And so they're going to be tired an awful lot because they're not sleeping. Okay? Another thing that causes a lot of fatigue is oxytocin release. Oxytocin, the love hormone, the reason people take a nap after they orgasm is because oxytocin makes you sleepy. Okay? And when you breastfeed your baby and you get a surge of oxytocin, it makes you and baby very sleepy. It's why it used to be called a risk of breastfeeding, or a negative side of breastfeeding was that you're tired all the time. It's not a negative. You're supposed to be sleeping. Okay? For 40 days, you're supposed to be doing almost nothing. All right? That's not an accident. That culturally we've always done that. Moms who have babies need to rest as much as they can for the first 6 weeks. Okay? And the more that they rest, the easier postpartum is. The more they fight against it, the more they try to go back to being a normal person and forget that they're mothers, the more they're going to struggle. Okay? You can do whatever you want, but I promise if you just hang out on the couch for 40 days, you'll be a much happier person. Okay? So it's not an altered sleep pattern. It's not a disorder. It's supposed to be there. Okay? It's not unusual for moms to see a little numbness and tingling in their legs and to be easily dizzy. Numbness and tingling is part the epidural, part the stretching of the whole birth process. All those nerves get stretched real well. A little back pain is normal with or without an epidural, but epidurals make back pain a little bit worse because everything relaxes around the vertebrae and they get a little bit out of joint. Okay, and they put some strain on those ligaments when they're pushing that they don't normally notice. because of the epidural. It tends to cause a little lingering back pain. Not the end of the world. Headaches, very, very common postpartum, especially across the forehead, because mom spends all her time doing this, okay? And she never looks up. And her posture is horrible. They're like this all the time. And they go, why does my head hurt? My head hurts just doing that, okay? Or they do like this. Crazy yoga positions trying to get the baby to the breast, and they wonder why they have these weird aches and pains. It's because their body mechanics have changed. And you got to kind of step back and go, have you noticed what crazy position you're lying in? Let's straighten you up a little bit and see if that makes it better. Okay? And so the other thing that contributes to headaches is that the breasts are now much larger than they used to be. Okay? A woman usually gains a cup size in the first trimester of pregnancy, and then another cup size at the end of pregnancy and through the first month postpartum. So the breasts go from B's to D's. And when you all of a sudden go from B's to D's, that's an awful lot more weight pulling down like this. And it makes it hard to hold your head up, okay? So you get more tension headaches that come over the back of the head and across the forehead. Those are normal, okay? Those are common. The headaches we worry about when we talk about postpartum gestational hypertension, we talk about like, cerebral headache. A cerebral headache coming from blood vessel spasms in the brain is migraine type, right? And so it is not, I get a little pain and current here. That's not a headache. That's a 1 or 2 on a scale of, that's no big deal, okay? It's 8 or 9 out of 10. I feel like my brain is going to explode from the inside out. That's a big deal, okay? So assessing what kind of headache they have, or any headache and high blood pressure. Automatically, you got to be suspicious, right? Renal system. Everything's going to return to normal over the next couple of weeks. Proteinuria, it is extremely common to have proteinuria immediately postpartum. Where's the protein coming from? Lochia, okay? It's there. So every once in a while you'll see people like readmitted, like where they have blood pressure issues on the second day postpartum, and some boneheaded doctor will order a 24-hour urine. It is useless, a 24-hour urine in a woman with a little bit of blood pressure in the first week postpartum. She's always going to have proteinuria. It's extremely common to have proteinuria. It's not very useful, okay? We throw that proteinuria out for a little bit immediately postpartum. Now, there's 6 weeks postpartum. It might be useful. But anybody with high blood pressure and a headache postpartum usually ends up with another 24 hours of MAD. Okay, we don't really use the postpartum preeclampsia. We don't treat it the same as postpartum. And they have rapid, sustained natriuresis and diuresis. I had to look up natriuresis. What's natriuresis? Salt. Who said salt? Bing, bing, salt. It's a release of, they lose a lot of salt. And you see that urinary output? 3 liters a day. That's a lot of pee. Okay? Respiratory alkalosis is compensated by acidosis. I could care less. But the big thing is relief from dyspnea. All of a sudden, all that shortness of breath they've been having for all those months is gone. And it's because everything settles back down and everything returns to normal. So basically, all of these changes postpartum are just the reverse of all the things that they changed when they became pregnant, right? Hormonal alterations cause the skins to change back to normal, and they kind of disappear. Striae gravidarum, once you got them for life. What's a striae gravidarum? That's right, they're battle wounds. You deserve them. They're scars. Keep them. Those are your. That's the result from battle, and they tend to get real silvery as they get older.
They're just tiger stripes.
That's right, tiger stripe. That's from being a mom. The immune system. RhoGAM. There was a little question about RhoGAM on the last test. What is RhoGAM? It's an antibody, right? Good, good. So it's an immunoglobulin, actually. So RhoGAM is given to women who have positive blood type or negative blood type?
Negative.
Negative blood type. Do we give them to all women with negative blood type?
Only. Yes.
Only. Well, we give it to all women in pregnancy because we don't know the baby's blood type.
Right.
But postpartum, do we give them to everybody?
No.
Only babies who have positive blood type. Okay? So if mom has negative blood type and baby has positive blood type, we give mom RhoGAM postpartum to hide the fact that she had a baby with a positive blood type. Why? What does a positive blood type in a baby do? What could it do?
Attack its body.
There you go. Immunity to the next baby.
But because here's the thing though, because I know in the book it says it only lasts for 3 months,
Yep.
but you need to go back for another shot, so you.
No. Not postpartum, just one shot is enough.
Right, but I'm saying, you're right.
So it lasts for 3 months, right?
Yes.
So we give it at 28 weeks, right? Because 28 weeks is 12 weeks from delivery. So it covers the last trimester, the last 12 weeks. And then when baby's born, we give them another shot.
But then
Okay.
it only goes.
And that, yeah. So we're really covering them for 6 months. Okay?
Yeah.
The last 3 months of the pregnancy and the first 3 months of motherhood. And the trick is, most moms and babies do not share blood. Okay? Mom's blood flows up to one side of the membrane, baby's blood flows up to the other, and they pass things back and forth without sharing blood. That's important to understand because if they shared blood on a regular basis, baby's blood type would always have to be mom's blood type. Okay? Baby wouldn't be able to survive having his mother's blood in his body. Okay? He just can't unless his blood type is exactly hers. So what happens is when there's trauma, when there's a placental abruption, when there's a birth, when there's any kind of trauma, shearing forces on that placenta, it's possible, since we've disrupted that vascular bed, for a little blood to go back and forth. Okay? I had a baby who accidentally bled to death in his mother's womb, and we don't know how it happened, but all of his blood went into his mother. He bled to death. Okay? Very, very sad. That mom needed 10 shots of Rogaine because she had all of her baby's positive blood in her negative blood in her negative body. And so we had to hide that blood from her body. Okay? And so what Rogaine does is it masks the positive blood type so the body can't detect it. Okay? So if there's a little bit of blood in maternal circulation, Rogaine will keep them from becoming what's called isoimmunized. Okay? Now, it doesn't hurt baby number 1 at all. He's already out. The isoimmunization happens after he's born. But once mom's body has recognized a positive blood type, it will always fight against the positive blood type. Okay? And so then she becomes immune to her baby. And it works by actively trying to kill the baby. It's called isoimmunization. And it causes hemolysis throughout the baby's blood. They start to lose blood rapidly. They become profoundly anemic. They start to develop hydrops fetalis, where they start to swell and get like someone with congestive heart failure, but all over their body. And it gets worse and worse until they die. Believe it or not, we actually give blood transfusions to those babies in utero, right through the abdomen, into the umbilical vein, and we give them a blood transfusion to keep them alive. Isn't that the coolest thing ever?
Yeah.
It's called pubs. So after birth, anybody with a negative blood type, we test their baby's blood type to see if it's positive. And if it's positive, they get a shot of Rogaine. If it's positive and their Klein-Auer-Beck comes back positive, where we actually detect fetal blood in maternal circulation, they get 2 or more shots of Rogaine, depending on how much they need. Okay? But all you need to know is that everyone negative gets a shot of Rogaine if they have a baby with a positive blood type to protect baby number 2 or subsequent pregnancies. Okay? And Rogaine is a blood product. Okay? It's issued by the blood bank, and it has to be verified by 2 RNs. It is a blood product. Okay? The reproductive system, there's a complete involution of the uterus. The placenta slide heals, and as it heals, when you think about that lobia rubra, alba, serosa, that is exactly the same thing you see with wound healing on the outside. Okay? Think of a moist wound on the outside and how it heals. It bleeds, and then it gets this like kind of yellowy, wet scab. That's the lochia alba, and then it lets this little serous leak for the last phase of wound healing, right? It's the exact same thing. It's just the placenta, the wound where the placental bed used to be. Okay? Vaginal changes. What used to be a birth canal goes back to being a vagina again. How wonderful! And then you can't pass an 8-pound baby through that again until you get your birth canal back, right? You got to switch out your organs. And what do you think is causing the majora and minora to become flaccid in the initial postpartum area, the first 6 months? What's missing because she's breastfeeding? It's not progesterone. I know you want to think progesterone. No, the other hormone that's not progesterone that causes things to build and be big. Estrogen, right. So without estrogen, they become menopausal. Okay? And they go through the same things, kind of menopausal. The labia become very thin and soft, and they look like old lady lips. And you just got to understand that old lady lips are normal in a breastfeeding woman, and she needs to act a little bit like an old lady when it comes to having intercourse. You know, lots of foreplay, lots of lubricant, that kind of thing, so she can have intercourse without pain. Because it's never normal to have painful sex. Never. Never. Common, yes. Normal, no. Should be treated every time, yes. Dyspareunia, bad.
Yeah.
That was a question on the test.
Yeah.
Yep. Menstruation and ovulation. Non-lactating women, meaning women who are formula feeding, their ovarian cycles begin right away, 6 to 8 weeks postpartum. It's not unusual to have a period 6 weeks or 8 weeks postpartum. Usually it's not that early, but they will begin right around there. Usually by the 12th week, they have had their first ovarian cycle. Okay? And that's because when you're formula feeding, the body thinks your baby died. And it wants to do one thing, that's get pregnant again. So it returns immediately. That's the syndrome of Irish twins. Okay, having 2 babies within a year. You never see breastfeeding babies 9 months apart. Never. Okay, but boy, you see a lot of formula feeding babies 9 months apart, 10 months apart, 12 months apart. Okay? Very rare. Okay, fine. Very rare. Okay, now in lactating women, we have delayed ovulation and delayed menstruation. Okay, because we've suppressed the estrogen and the progesterone, and that makes it so that the ovaries aren't ovulating, and the baby is, and mom's lactating, and we have what's called lactation amenorrhea, which we touched upon briefly when we talked about contraception. Okay, the average postpartum woman who's breastfeeding has her first period about 9 months postpartum, gets pregnant about 14 months postpartum, and has a baby every 24 months, which is the way the body is designed. It doesn't want you to have a baby to get pregnant within 12 months postpartum. Okay, so. Lactating women will not have any bleeding for the first 6 months. Those who do will have like a half-day period right around 6 weeks postpartum, and then nothing. And that's the last shedding of the endometrial scar from the placental bed. It's not a period. It's just like a half a day or a day of bleeding. A period in a lactating woman is defined as 2 or more days of bleeding that occurs after the 8th week postpartum. Okay. Any bleeding in the first 8 weeks, especially if it's less than 2 days, is not period bleeding. It's postpartum bleeding and nothing else. Okay?
You said 8 weeks?
Yes, 8 weeks. 2 or more days of bleeding, more than 8 weeks postpartum. Gastrointestinal system, everything kind of slows back down initially, then returns. The abdominal wall. You guys read about the diastasis recti? Diastasis recti. You got these rectus abdominis, and they're in there nice and tight, holding you up so you can stand up, right? It's good stuff. But they got to make room when the baby comes. And so that uterus grows and it causes them to spread out. And they separate the 2 muscles, okay? And leave a hole in the middle of the abdomen where there's no muscle in here. And that's called the diastasis recti, okay? Immediately postpartum, it's more than 3 to 4 centimeters apart. You put your whole hand in there and feel, I've actually felt the spine going through the abdomen on a really skinny woman. Because there's just nothing there anymore, okay? And so when you're doing your postpartum assessments, have the woman lay down flat on the bed and pick her head up off the bed a little bit, and you'll see this big tent form right in the middle of her belly, where everything goes bloop, and she's got her rectus abdominis are out here, and the middle is missing. And so all the intestines and everything poke out through there, okay? That's called the diastasis recti, that space between. It will grow back in the first few weeks postpartum, and when it is less than 3 finger breadths across, you put your finger there, have a little sit up, and it's less than that, then they can start returning to abdominal workouts. Yeah. Talked about all that. Okay. Cultural assessments. We talked about how I don't like cultural assessments, right? Because you can't say, you're going to do this because you're Hispanic. You have to do that because you're black. You have to do that because you're Asian. You can't do that. But what you have to do is be comfortable and cognizant of various differences, okay? There are people, like we were talking earlier about in Korea, 21 days with a laying in period, and everything is hot. Fine. Let them wear sweaters in postpartum. Who cares? It's not going to hurt anybody. It's okay. Just recognize that people are going to do things differently because it's cultural, and they're okay, and you're okay with that, right? When the cultural practices are harmful, then we should go, well, maybe not, okay? It was a few years ago, it was very common for Hispanic women not to feed their babies in the first 48 hours. The idea was that the milk that was in there was old and bad, and you couldn't use it anyway, so they'd wait for it to go away, and then like 72 hours postpartum, they'd start breastfeeding their babies. Problem with that is that by then it's too late. They've already shut down their breastfeeding system. Makes it very difficult to get that up and running again. So pay attention to them. Try to go, well, maybe we could do this instead. Or, you know, if we do that, we got this increased problem over here. Let's see what we can do. Okay? All right. My God, I take forever with doing these things. So, early on we talked about how important ambulation is. Kegel exercises. Who knows what a Kegel exercise is? Squeeze. It's a perineal muscle squeeze, right? So we know that the pelvis is a basket of muscles, okay? They kind of run all crisscross in there, holding everything together across the bottom. So when we do Kegel exercises, what we're doing is we're tightening up the levator ani and the pubococcygeal muscles, which there's the levator ani goes across the bottom, and the pubococcygeal goes from front to back, okay? And we're tightening them up, and we're holding it for a little bit. It's a little isometric kind of thing, kind of like going and tightening your bicep. And what I have women do when I do Kegels, I have them sit very still, very flat and balanced, and then I have them imagine that they're going to tighten their muscles and come up, okay? And as a boy, I can do Kegels just like you guys do. It just doesn't do me any good. But you tighten the muscle and imagine an elevator going up to the top of a building. Bing, gets to the top of the building. Now relax. Ooh, slowly go down again. And you can feel it. If you all practice, imagine, put in your brain, this is my pubococcygeus and this is my levator ani. These are my pelvic muscles. I can feel them on the outside. Tighten them, hold them, and go up. And then go down. There actually are barbells.
There are barbells.
They're little weights that you can put in the vagina and have them hold the weights in place. Yeah. And they go heavier. You get heavier as they get better at them. You start with a little lightweight and you get bigger and bigger and bigger. Yeah. Yeah. Yep.
This is after pregnancy?
Anytime.
Anytime.
Yeah. The French do a lot of work. The French women do a lot of work on their vagina. I don't understand why, whatever. But Kegel muscles are important because they help return urinary function. It helps fight against stress incontinence. But they start slow and gradually increase. And what I usually will teach them is when you're driving, you put your foot on the brake, do a Kegel. When next time you come to the red light, put your foot on the brake, do a Kegel. You're going up and down stairs, you take a step, do a Kegel. Do it again, take a step, do a Kegel. And then go up the stairs, okay? And just kind of work it into the daily routine so they're doing Kegels several times throughout the day to rebuild that muscle tone down there. Frequent rest, inadequate sleep, duh. Good weight loss. How much weight should a woman lose postpartum? How much weight did she gain postpartum? She gained up to 40 pounds is normal, but how much did the pregnancy weigh?
30.
30, right, 28 to 30 pounds. I usually say 28 pounds, okay? What is a reasonable expectation of weight loss postpartum? Are they ever going to get to their pre-pregnant weight?
Maybe.
Not likely. Not likely. Because as we age, we get bigger, okay? It happens. Britney Spears did it, right? But as we age, we get bigger. It's just part of getting older. You never get to be 18 again, right? So the average woman will maintain 10 pounds for each of her first 3 pregnancies.
Oh my God.
So a first-time mom will come away 10 pounds heavier a year or 2 later. A second-time mom, 20 pounds heavier. A third-time mom, 30 pounds heavier from her first pre-pregnant weight. So you start at 110, you have 3 kids, you finish at 140, and that's normal. Okay? Some people, fine, you're petite, you're little, you can't gain weight no matter what, you make us sick, do what you want to do. Everybody else is normal, and they gain about 10 pounds. Now, that doesn't mean a woman who has 6 children gains 60 pounds. It stops at 3. Okay? And so they just gain up to the first 30 pounds. And so it's not unusual. You're 18, 19, never had a kid, bumping in around 110 pounds. You turn 40, you've had 3, 4, 5 kids, you're about 140 pounds. That is perfectly acceptable. That's where you should be. That's reasonable. Okay? But it's important to teach that you're not going to get that back to pre-pregnant weight. You don't ever get to be pre-pregnant again. If you get lucky and do it, fine. But most women are not. And reasonable expectations are that it takes a while. They lose a lot of weight really fast in the first week or two, 28 pounds as a matter of fact, because they've lost all of that pregnancy stuff. And then they just got to lose the rest of the fat that they accumulated. Okay? You want to make sure they're peeing every few hours. Like I said, pooping comes later. And when they do poop, it's not constipation. It's fine. Perineal care, we want to teach them perineal care. We want to make sure that they're paying attention to washing their bottom with what we usually use is just a warm bottle of clean water, nothing else. And we spray the bottom. She sprays after she pees or poops and then pats herself dry. Okay? Just kind of wash any blood away. Good hand washing. We do not use tampons in the first couple weeks postpartum. I can't imagine anyone who would, but no tampons. Okay? We're already at increased risk of infection. We've got an open source of, what do they call it, an openitis of infection in the uterus with the placental bed. We don't need to be inserting anything into the vagina, be it fingers, be it pads, be it anything, because it can track up into the uterus. So we don't want to do that, okay? So tampons are bad, pads are better. Okay? Cesarean births, same thing, normal perineal care. They're still bleeding and all that wonderful stuff. They don't have a vaginal laceration, but they've got an abdominal laceration that we need to take care of. And again, it goes back to early ambulation, okay? And if they can't ambulate, you got to do their peri-care for them. So they lay in the bed, you open things up, spray them down, pat them dry, just like you would if they were sitting on a toilet, and change all their pads out. Okay? Looks like it's about time for a break. All right, let's go ahead and stop and we'll take a break.